So, role of preoperative assessment and enhanced recovery after surgery protocols. So what are the objectives of the talk? I'm going to start off with the methods that are available for preoperative assessing a patient, with particular focus on CPX testing. I'm then going to move on to ARAS protocols and talk particularly about nutrition, management of post-operative ileus, and also the use of mechanical bowel prep. The other objective of the talk is to keep you all awake this morning. So with that in mind, I thought I'd show you a picture of this guy and see whether you knew, apart from the fact it's a bit fuzzy, does anybody know who this guy is? No, his name's John Cabot. Giovanni Cabotto. Now, the reason why I mention him is because he links Bristol to Canada. He originally is an Italian, but moved to Bristol in 1490. And I think King Henry VII knew what he was talking about, or certainly knew about Canada when he asked John Cabot to seek the islands and the countries of the heathen towards the west. So this is the ship that he sailed in, the HMS Matthew, and that's still moored in Bristol. And on June the 9th, 1497, he reached the New World, and the landing spot is either Cape Breton Island or Labrador. So, moving on. The age of patients undergoing major urological surgery is increasing. And we know that with increasing age, there's an increase in mortality and morbidity. But if you identify appropriately older patients, they can have the same outcome as younger patients. So the objectives of any preoperative assessment are to allow access to appropriately chosen older patients, to identify unsuitable patients or those that would benefit from being managed in an HDU or high dependency environment, and equally to identify low-risk patients who can be managed on the wards. Now, the idea is to make efficient uses of ICU services, but also identify reversible or treatable problems that a patient may have preoperatively. So what can we use? Well, we can use age, but that's known to be a poor discriminator. Initial attempts were aimed at finding myocardial ischemia, and the thought was that that carried about a 70% mortality rate post-operatively. From there, we moved on to the development of scoring systems, which gave some objectivity to assessment. Everybody's aware of the American Society of Anesthesiologists score. There's also one called the Goldman Cardiac Index, and they were formulated quite some time ago. More recently, there are a few more scoring systems that take into account surgical risk. One is called the POSSUM score, and we'll come on to that in a second. And then a fairly new one, the ACE27 score, particularly formulated for cystectomy. So what's the POSSUM score? Physiological and operative severity score. The idea behind it is that it gives you a 30-day predicted outcome after surgery. It's based on 12 physiological parameters and 6 operative parameters, and you can see the result that you get at the bottom. So you get a physiological score for the patient, you have an operative severity score, and then you have a predicted morbidity and mortality. Now, it's quite useful in terms of comparing outcomes between departments or surgeons because it takes into account the case mix. It does provide some objectivity, but it over-predicts in low-risk patients and also in older patients, so that can be a problem. So what do the anaesthetists use? Well, they obtain some information on comorbidities and also make a subjective assessment of their exercise tolerance. Now, exercise tolerance is described according to metabolic equivalence. So 1 MET is equal to resting energy expenditure. 4 METs is the ability to climb 2 flights of stairs. Now, if you can't do this, that doubles your chance of a cardiovascular event post-operatively. There are a variety of other methods, ECGs, echocardiogram, respiratory function tests, but unfortunately these don't give a functional assessment of the cardiopulmonary system and don't have any correlation with perioperative outcome. So with this in mind, a chap called Older from New Zealand in 1988 admitted 100 patients before major abdominal surgery to the intensive care unit, and he performed invasive measurements of their cardiovascular system, pulmonary system, and renal system. He was trying to find a particular marker that could then identify risk. There was a wide variety of measurements, but an actual marker was elusive or remained elusive. So this leads us on to cardiopulmonary exercise testing. So we know that major intra-abdominal surgery is associated with an increase in oxygen demand of 40% or more. A patient's functional capacity relates to their ability to increase their cardiac output in relation to this increase in oxygen demand. Now, when there's an imbalance between cardiac output and oxygen demand, anaerobic metabolism occurs, cellular dysfunction occurs, which can lead to perioperative morbidity and death. So the risk of a particular procedure is a product of the type of surgery the patient's undergoing and also their cardiopulmonary functional capacity. So this leads us on to cardiopulmonary exercise testing, or CPX testing. So what this does is objectively measures the ability of the cardiopulmonary system to deliver oxygen to the tissues under conditions of stress. Now, it's not routinely used, but it's becoming more common. It's inexpensive, non-invasive, and can be performed in the outpatient department. The premise of CPX testing is that if a patient's unable to sustain aerobic activity and increase their cardiac output in relation to any increase in oxygen demand, the same is likely to happen in the perioperative period, leading to a poorer outcome. So it uses either a bicycle ergometer, a treadmill, or a hand crank, and also a respiratory gas analyzer and an ECG. So what does it measure? There are several measurements: exercise and resting ECGs, exercise and resting pulmonary function tests, and also oxygen consumption. But it seems that the most important thing, or the important measurement, is the anaerobic threshold, and that's the point at which anaerobic metabolism is needed to supplement aerobic metabolism. Now, it's independent of motivation and age, and it occurs well before the maximum aerobic capacity, so you can readily obtain it in elderly patients. It's expressed as a value of oxygen consumption indexed to a patient's body mass. And it's actually the point where carbon dioxide output exceeds the increase in oxygen consumption. So, we know that oxygen consumption increases after surgery, so this led Older to come up with this concept of the surgical anaerobic threshold. So if you exceed this, you're more likely to have a poor outcome. So he had a look at 187 patients with CPX testing. He had 55 patients who had an anaerobic threshold of less than 11, and of these patients, 10 died, which gave a mortality rate of 18%. 132 patients had an anaerobic threshold above 11, only 1 died, and that gives a mortality rate of 0.8%. Now, when he combined this with evidence of preoperative ischemia, the mortality rate went up to 42%. So this is his follow-up publication, and what he wanted to do was not only identify high-risk patients, but also come up with an idea of how to manage them post-operatively. And according to their anaerobic threshold or any evidence of preoperative ischemia, he placed patients either in the ICU post-operatively, the high-dependency unit post-operatively, or managed on the ward. And what he found is, as you can see on the left-hand side, there's a high predictive value of identifying high-risk patients, with the vast majority of deaths occurring in the high-risk group. But equally, there was a high predictive value of identifying patients who were low-risk, with no deaths occurring in the low-risk group. As to whether the management strategy led to a better outcome, that's still under discussion. So in terms of CPX testing, it appears to be a promising method of evaluating patients preoperatively. There have been some positive results from vascular surgery, but there are conflicting results from upper GI surgery. There's little data on its use in urological surgery, but this is changing. There are several centres in the UK that are using it, including Bristol. Again, mentioning it before, the ultimate aim is to allow treatment to older patients and also make more effective use of ICU resources. So,
Anthony, how does that compare to, I think we have a lot of ASA categories?
It's slightly objective, but everything that we've mentioned before, be it scoring systems or echocardiograms or respiratory function tests, it doesn't actually work out what your functional capacity is. Everything works together. Your heart works with your lungs. So getting a static picture of your heart and an ejection fraction doesn't actually correlate with outcome, whereas this is one of the few things that appears to correlate with outcome. If you can find a particular marker, like the anaerobic threshold, which is a combination of your heart and your lungs, it gives you a better idea of, or get a better indicator of cardiovascular risk post-operatively. So a short interlude now.
Is that mortality is that 30-day mortality?
Yeah, yeah. So another quick interlude. I wondered if anybody knew who that chap on the right-hand side was. Darwin. Has anyone heard of Isambard Kingdom Brunel? No, okay. So he's known as the father of the Industrial Revolution and also modern engineering. He was responsible in the 1800s for revolutionizing public transport. He built the Great Western Railway, which runs from London to Bristol. He also built this ship, which is the SS Great Britain, which is the first propeller-driven transatlantic iron ship. Now, to give you an idea, this was 1840. Everything before this was built of wood, and when he mentioned about the fact that he was building a metal ship, everybody thought, you're clearly bonkers. But anyway, he built it. And at the top left-hand corner, that's the Clifton Suspension Bridge. Now, he designed that during life, but it was only completed as a memorial to him when he died. A couple of more pictures. Strong aeronautical history in Bristol. Concorde was built in Bristol. This is its last flight, and you can see it passing over the suspension bridge. And more recently, the largest airliner in the world, the Airbus A380, again built in Bristol, and then you can see its maiden flight over the suspension bridge. So, that leads us on to enhanced recovery after surgery. Now, this is also known as fast-track surgery, and it originally comes from Denmark. The idea behind ARAS is to reduce the effects of the surgical stress response. It integrates a variety of interventions to maintain physiological function and also facilitate an earlier recovery. Now, the vast amount of evidence comes from colorectal surgery, where it's used widely. So, is it effective? The short answer is yes. Cardiopulmonary function is improved. There's an early return of bowel function. There's a reduction in hospital stay, complications, post-operative fatigue, and there's an earlier resumption of normal activities. There's nothing new with ARAS. All we're doing is using what we already know in clinical care. So don't be scared by the amount of information on the slide. This is the ARAS protocol from Bristol. The idea that we weren't doing things as well as we could have been doing came from the ward staff, and in conjunction with the dietitians, the anaesthetists, the community staff, the stoma care staff, this is the ARAS protocol that was formulated. Now, don't read all through it. I've highlighted some things that I'm going to talk on a little bit later in the talk. So, was it useful in Bristol? Well, they looked at 112 consecutive patients, 56 before implementation and 56 after. There was no difference in mortality, morbidity, or readmission rate, but you can see from the box plots, particularly on the right-hand side, that there was a reduction in hospital stay of about 4 days. So it did make a difference. Now, moving from there on to one of the particular focuses of the talk, I'm going to talk about nutrition now. Yeah. 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 Something I've noticed. And we'll come to that a bit later in the talk as well. So nutrition. Poor nutrition is detrimental to outcome across all surgical specialties, often associated with comorbidities and also underlying disease. Poor nutrition, particularly for cancer patients, is an independent risk factor for complications, hospital stay and costs. So who should receive preoperative nutrition? Well, the European Society of Parenteral and Enteral Nutrition state that people should receive 14 days of enteral nutrition if they have weight loss of 10 to 15% in 6 months, a BMI of less than 18.5 or a serum albumin of less than 30. And you just need to think about some of your cystectomy patients, and there'll be a significant number of them who achieve those criteria. There's another way of doing it. The British Society uses this tool, which is called the MUST tool. It's a 3-step process whereby you assess someone's BMI, you assess their weight loss, and also assess the effect of any acute disease. And you score them, and you only have to have a score of 2 or more to be high risk and require nutritional support. So how do we manage these patients? Well, dietitian input or nutrition input is important, but in the most part, all they need is a standard whole protein oral supplement, such as Ensure. I don't know whether you have this here, but it's cheap and it makes a difference. 5 to 7 days of Ensures 3 times a day has been shown by 3 randomized control trials to improve morbidity and also reduce hospital stay.
That is strictly
Preoperatively, to the point where it's been shown that delaying surgery, even cancer surgery, will improve outcome if you provide these patients with oral nutrition.
So we're telling patients try to lose weight. Make your belly smaller.
Have these. This will work. So, Moving on to the stress response, particularly with relation to nutrition and metabolic aspects. Now, the surgical stress response, as everyone remembers, is characterized by an increase in catabolism. Substrates are diverted from their normal role, which is physical activity, to the immune response and also healing. It's characterized by hyperglycemia, and that's facilitated by cortisol and catecholamines promoting glycogenolysis and gluconeogenesis. There is also a relative lack of insulin. Again, catecholamines inhibit the production of insulin from the pancreas, and there's also a peripheral insulin resistance, which is due to a defect in the insulin receptor intracellular signaling pathway. So insulin resistance includes this lack of insulin, this resistance, and also this hyperglycemia. It's a major variable influencing length of stay, causes poor wound healing and increased risk of infective complications. The degree of resistance is associated with the extent of surgery. If you control it, you can reduce morbidity and mortality by up to a half. Again, most of this data comes from colorectal surgery, but there's a BJU article in 2008 which shows a similar picture in cystectomy. The majority of patients having a cystectomy are malnourished. They then undergo a long procedure followed by immobilization. This depletes their carbohydrate stores. They have hyperglycemia, insulin resistance, and then protein loss, which takes up to 6 months to recover. So how do we reduce it? Well, adequate pain relief is important. We know that acute pain stimulates the stress response. In terms of the type of pain relief, epidurals are better at attenuating the response than parenteral opioids. The idea is that an epidural will stop the catecholamine and cortisol response. And the last two I'm going to talk about a little bit from now on. Pre-operative carbohydrate loading, very much like the process that marathon runners go through, and also avoiding an interruption to oral intake. So carbohydrate loading. Before I go on, there are two things about carbohydrate loading. The practice of making patients nil by mouth from midnight is based on the worry of aspiration before elective surgery. There is no evidence to support this. Patients can receive solid 6 hours preoperatively and clear fluids up to 2 hours preoperatively with no increased risk of complications. And they are guidelines that have been adopted by the Royal College of Anaesthetists, the American Society of Anaesthesiologists, and anaesthetic societies across Europe. So carbohydrate loading uses a clear carbohydrate drink 2 hours before surgery. It reduces preoperative thirst, hunger, anxiety. It reduces the post-op insulin resistance. It reduces nitrogen and protein losses and leads to a shorter hospital stay. So it works. So moving on to post-operative nutrition. Again, the practice of keeping patients nil by mouth post-operatively is because of concerns regarding anastomotic dehiscence and also worries about post-operative ileus. There have been a huge number of RCTs and meta-analysis on the subject. One of the first ones in 2001 was published in the BMJ. At that point, everybody knew that early feeding was tolerated, but whether it was beneficial was unknown. Now, the figure looks quite impressive, and the relative risk reductions look quite good for dehiscence, wound infection, pneumonia, and mortality, but they're not actually significant. But what the paper did find was that there was a decrease in hospital stay. There was certainly no advantage for keeping patients nil by mouth, and there was no detrimental effect on the anastomosis. So more recently, a Cochrane review in 2006 found a direction of effect towards a reduction in surgical complications. And they also found a reduction in mortality rate, and we'll just come to that in a second. Last year, another meta-analysis, reduction in complications, certainly no benefit to nil by mouth. They also found this reduction in mortality rate, but the mechanism associating the two is unclear, and I'm certainly not saying that if you give someone early enteral nutrition, it will reduce their mortality rate. It's just an observation that is an evolving observation, or the idea behind it is not explained. So, moving on to post-operative ileus. Bowel complications after cystectomy, as you all know, one of the most commonest complications. Patients get distended, they have pain, nausea and vomiting. Now, normal bowel function relies on the enteric nervous system, central nervous system, hormonal influences and neurotransmitters. Ileus occurs because of peritoneal irritation interfering with those normal pathways. Which leads me on to bubblegum. So I've got some facts for you about bubblegum. So in the UK, 20 million people consume more than 935 million packs of gum per year. In the UK, 9 out of 10 of every single paving slab have had a bit of gum stuck to them. If you chew it, it burns 11 calories per hour, but also it might have an effect on the gastrointestinal tract. So the idea is that if you chew chewing gum 3 times a day immediately post-operatively, it can reduce the length of your post-operative ileus. Now, it's described as a form of sham feeding. Now, sham feeding means that a substance enters the mouth but doesn't enter the stomach. It stimulates cephalovagal activity, and what that does is it increases motility and inhibits the inhibitory sympathetic input to the bowel. The other things it does is increase your gastrointestinal hormones, such as neurotensin, cholecystokinin, and they're all important with vagal stimulation of smooth muscle. There's also an increase in its saliva and pancreatic juices, and some of the ingredients such as sorbitol and hexatol may well play a role. So we added it to our ARAS protocol, and we looked at the time to return of bowel function as signified by the first defecation. And you can see from the box plots there was a 2-day reduction, or bowel function returned 2 days earlier in the patients who were treated with chewing gum. So in terms of an economic impact, again, there's been a lot of data from colorectal surgery, but in the US, post-operative ileus are kept.
So, the error bars, so how do you do statistics on that?
Say that again?
It's a box plot, right?
Yeah.
And your average is lower, but what are the statistics around?
So,
Confidence
yeah, I can't tell you off the top of my head, but with all cystectomies, within a year or 18 months, I mean, this is 56 patients before and 56 patients afterwards. Within that year, you will have some real outliers, some patients who do really badly, who stay in for several weeks because of a complete catastrophe. So using medians and box plots, the idea behind that is removing those outliers and getting a real idea of what's going on. But I can't remember the confidence intervals.
So can you conclude that that difference is statistically?
Yes, yeah, it was less than 0.001. It made a big difference, and people could see it as well. The nursing staff were saying these patients are getting up and going much more quickly. There is a proviso, and I'll come on to that in a second. Yeah. Thanks very much for that. So, in terms of money, ileus accounts for $1 billion expenditure in the US now. Gum costs 4 cents. So, based on 79,000 colectomies costing $1,500 per stay, an outlay of $47,000 can save $119 million. But we didn't find any difference in our hospital stay with the addition of chewing gum, which is strange because patients were getting up and moving around much more quickly. There were some unique things to our department which we identified. On the day of discharge, you'd find out the patients weren't coping at home. In Bristol, there were no interim care beds or cottage hospital beds for them to go to have some more rehabilitation. There were also some delays with stomacare tuition, and also there were concerns with sepsis after stent removal. So patients were being kept in for 24 hours after the stents were being removed, just to make sure that they didn't have any problems. So how else can we reduce post-op ileus? Now, prokinetic agents, they're included in the Bristol protocol, but unfortunately, there is no evidence to suggest that they lead to an earlier return in bowel function. So metoclopramide, erythromycin doesn't seem to make a difference. It's important to avoid fluid overload. So there has been a practice over the years to use litres of fluid in excess of losses. So what you need to do is to use the right fluid to maintain balance. If you give too much fluid, you'll interfere with oxygenation and also anastomotic healing, and also lead to post-operative ileus. You should identify the fluid cavity that you're losing fluid from and choose the right fluid to replace that. NG tubes, all NG tubes do is prolong your post-operative ileus, lead to fever, atelectasis and pneumonia. Epidural anesthesia is very important as well. Again, it attenuates that thoracolumnar inhibitory sympathetic input and leaves the parasympathetic or stimulatory input untouched. And the last one is avoiding mechanical bowel prep. which I'm going to come on to now. Now, mechanical bowel prep.
Sorry,
Yeah.
back kinetics, one of my colleagues uses erythromycin.
Yeah, when I first started, I worked for a chap called Professor Alderson in Bristol, and his thesis was on erythromycin, and it looked good, and it seems like it should work, but in the context of these protocols, it doesn't actually lead to an earlier return of bowel function. And we use it. We use metoclopramide 3 times a day post-operatively. So, bowel prep, major surgical dogma. The idea is that it reduces your infectious complications, it reduces fecal and bacterial load in the bowel, but bowel prep liquefies the stool, so that should increase your chance of spillage in an operation. And the idea that bowel prep reduces the bacterial load in the lumen is pretty much impossible due to the sheer number of microorganisms in the digestive tract. Now, this was challenged 30 years ago when it was suggested that it was unnecessary. Bowel prep is associated with bacterial translocation, dehydration and electrolyte disturbances, and there are 4 meta-analyses in the last decade which point towards an increase in anastomotic leakage with bowel prep. But what's the latest evidence? Well, there's a Lancet publication from 2007, 1,400 patients, a multi-center randomized controlled trial of bowel prep versus none, and the authors found that there was no difference in leakage or septic complications, mortality or dehiscence between the 2 groups. There's a more recent meta-analysis from last year which included 5,000 patients from 14 randomized controlled trial, and they found a similar thing. So the body of evidence demonstrates that there is no benefit to mechanically bowel prepping patients, so it should be abandoned.
Were there any differences in just diet?
So patients had a
Stay
normal...
on fluids alone?
No, so traditionally your bowel prep patients, the one end of the spectrum is 48 hours of clear fluids and bowel prep, and then go on for your surgery. These patients either had clear fluids the day before and then bowel prep, or they had a normal meal the night before. That was the difference between the 2. So, what suggestions can we make based on the literature? Well, we should probably consider a greater input from nutrition teams with oral nutritional supplementation where appropriate. We should be using carbohydrate loading up to 2 hours before surgery, early enteral nutrition as tolerated, and then avoid the use of mechanical bowel prep. So before we go into some questions, I thought I'd show you some pictures of the university in Bristol. Top left one, that's one of the halls of residences. This is the geography department. There's the music department, that's the Victoria rooms, and the Wills Memorial Building is the top right, which is at the top of Park Street now. That's the library. And that's it.